wouldn't make it that far. They told us we wouldn't make it to year one, really. But here we are, and we're today here at the Carter Center. You know, many of us know that former President Carter has recently passed, so I'm truly honored to be here in this space. You know, the idea of a peanut farmer from Georgia making it to the presidency, I think, is often lost on a lot of people, what a journey that was. Whether you are Democratic or you are Republican, you know, Jimmy Carter's journey, many people don't know, but Jimmy Carter's journey really started on a farm, not his farm, but the farm next door. And it was the farm that belonged to an African-American family. His mother was I believe, a nurse, if I recall it correctly. And so she worked many long hours. So public health was in his blood, but also the understanding of race, class, and culture was also in his blood. He spoke eloquently about the lessons that he learned from the family that basically raised him, where he slept on the floor in their home many nights, where they taught him about farming. It was that man, that black farmer, who taught him so much about farming. And it was the black woman that taught him so much about the importance of race, class, and culture in America. So I would like for us to take a moment to just remember that we, all of us, have lessons that we learn. We sometimes learn them in places and spaces that take us further in life than we can ever imagine in the moment that we get the lesson. So I just want to say thank you to him. I want to say thank you to the folks at Carter Center who have been amazing to us and to me, and to, honestly, to his grandson, who I had the honor of meeting later in 2024. And I'm humbled by the experience, and I'm humbled by the fact that CEG is here and in this space today. So if you could just take a moment. And with that, I would like to say thank you to the folks that also helped us plan to get us here today. The HIV Vaccine Trials Network, Dr. Daniel Griffin and his team out there, the Georgia AIDS Coalition, your team, and Emory University, and all of the folks there. We are actually going to have some welcoming remarks. Now, he actually picked my brain about what my speech was going to be about. And so I was like, oh, he kind of got butter from the duck today. So he, he was like, hey, well, you gonna get up there and talk about? And I was like, oh, I didn't realize that he was gonna probably use all this in his speech. But that's okay. You can use whatever you feel like you need to do. Okay? You do what you feel like you need to do today. Okay? No, you do you. All right. So I would like to invite up my new friend, the Georgia Department of Community Affairs Commissioner Christopher Nunn, and he'll tell you all about himself and how he likes to take my stories.
I have no intention of taking a story. I just am fascinated with the great work that you're doing. Congratulations on 30 years. This is a really important and impressive convening, and I appreciate the opportunity to be here today and to get to know you. Just out of curiosity, how many folks came here today from some place that was that required you to travel in? How many people are local versus a handful? Well, welcome to Georgia, welcome to Atlanta, welcome to the Carter Center. As we were saying earlier, the place where on January 15th, if the weather is warm enough that it'll melt the snow we got last week, which is really, really helpful as we prepare for another very important native son's birthday that we'll celebrate this weekend, Martin Luther King. The only other Nobel Peace Prize winning Georgian. So just want to recognize him. But I'll come back and talk a little bit about President Carter here momentarily. A couple of other folks I'd like to just recognize. Chairman Sharon Cooper, who is here. We enjoy such great leadership under our Gold Dome. They are in their third day of session, and she is here. That is a feat. I'm actually leaving to head down there, so appreciate the leadership that we have at a state level. Also, two of my team members, Brittany Pittman and Annika Woodruff, who are responsible for the Appalachian Regional Commission, where there is a connection, your home state or where your current home in West Virginia. Gail Manchin, former First Lady of West Virginia, a great friend, is the co-chair of the Appalachian Regional Commission, and we collectively focus on so many of the needs that I know you are interested in throughout the 13 counties that make up Appalachia. You mentioned that we're here at the Carter Center. I'm an Emory alum. All the Emory folks, you're here. And I was at a dinner last night, and I was talking with President Benvez about President Carter's funeral, and I have to share this story because if you rewind, I was actually born when Carter was governor in Georgia. Lived not too far from Plains. Everything you said is absolutely true about the way he grew up. Fast forward to later years at Emory, and I was involved in an Emory president's inauguration. That's a big deal. The new president, you got so President Carter, because the Carter Center is a part of Emory University, President Carter was a part of this inauguration, and he was in his regalia, and I was standing there, and as the rest of the delegation was headed up the steps, a local TV news reporter, almost knocked the president out of the way to get a good shot of the new incoming Emory president. And I was standing next to him, and I said, President Carter, it's really hard to get any respect as a former president, isn't it? And he kind of laughed. I was so glad that we as a country paid him the respects that he was due last week. And I think it's so special that you are here today at the Carter Center. So, really very briefly, because my role today is simply to say welcome and congratulations on this convening and the work that y'all will be doing today. I lead the state's community development agency, and community development is a really broad term. We focus on housing, we focus on infrastructure, we focus on economic development throughout the state. And you hear a lot about economic development, and our biggest focus in the world of economic development is on workforce. And I know through the work that we have done over the years that I have been here, particularly in Appalachia, how one of the biggest challenges, or a few of the biggest challenges to our workforce is an opioid epidemic, healthcare, and ensuring that people are able to participate in the workforce. I know that this kind of gets at some of the core of what you have been doing, the good work that you have been doing, and the good work that you aspire to do. And I imagine a lot of the hands and feet of making that happen are gathered here today. So I just want to tell you how important this is to all Georgians, to us as a state, and truly to the entire region and the entire country. So I wish you the best. As I said, I'm actually headed down to the Gold Dome, but my team will be here and looks forward to participating in the conversation. Thank y'all.
Thank you. So before I introduce the panelists today, I'm going to tell a little story. And I always like to tell this story when I start. Everybody that works at CEG has heard this thing 5,000 times, and they're like, please God, don't tell it again. But I'm about to tell it again. And I say it this way, that there's a train that's roaring through the Appalachia region. The engine of that train is the Oxycontin crisis, which many of us know. Today, it's a poly drug use crisis. The next car on that train is hepatitis C. Next car, hepatitis B, hepatitis A, educational attainment challenges, economic development challenges, workforce development challenges, with the caboose of that train being HIV. We've now got a sidecar of syphilis, a global outbreak of syphilis. Now, what do we have to do? We have to think about the fact that that train's rolling through the 423 counties as defined by the Appalachian Regional Commission, 13 states, and 26 million people. Our job at Community Education Group, along with you, is to be the boulder that stops that train in its tracks. We do that through economic, workforce development, and public health responses. Today, I've brought together some of the people that I think are the smartest, the brightest, and the most innovative in the country, if not the world, to have a conversation with me today about how we're gonna do this, and it starting with you here in Georgia in this room. Now, we're gonna get you to our Syndemic Summit in Huntington, West Virginia in September, but for right now, we wanna have a conversation about how we do this, because if we don't have a healthy Main Street, we don't have a healthy economy. Here's what I core believe, is that these issues are growing through rural communities throughout the United States, and we are not addressing it. We still believe that these are urban issues, and they are not. They are issues that are impacting rural America, whether that is the person who is going to be the one that changes your tire at the tire shop, or whether it's going to be the one that makes your dinner at the diner. We've got to figure out how we have them healthy, whole, both physically and mentally, and ready to do those jobs. Because we're not necessarily going to get those jobs back in coal mine. We're not necessarily going to get some of those manufacturing jobs back as fast as we want to. But guess what? Those people need to live, work, and eat, and we have a responsibility to. So what I'd like to do is introduce some of my friends and some of my colleagues and have them come up, and so we're gonna start having an important conversation. I'm gonna start out with my dear friend, Francisco Ruiz, who is the outgoing director of the Office of National AIDS Policy at the White House, but I've known him since he was knee-high to a butterfly, I couldn't jump over it. Take your first seat. Next, I'd like to introduce my friend, Dr. Daniel Driffin. He's the External Relations Project Manager for the HIV Vaccine Trials Network, which is doing some remarkable work, not just domestically, but across the globe, to ensure that folks have access to HIV vaccines and other treatments. I'd like to now introduce a good friend, and you guys probably know his work more than you might even know him. But Dr. Patrick Sullivan. He's a professor at Emory University at Rollins School of Public Health. He's probably one of the most prolific publishers. One of the other things that if you're in the HIV and viral hepatitis space, you might have used this thing called AIDSview or HepView. That's the guy. So I'd also like to introduce Alice Asher, Senior Health Scientist and Harm Reduction Unit Lead at the Centers for Disease Control and Prevention. And this is one of those places where I think the spaces, well, Alice is like one of those people that people say, well, government or bureaucracies don't have community-focused people in them. Not true, not true. She's one of them. Now, and Rep, I was gonna say hi, but he shouted you out, so, you know, there you go. He already did my work over there. So here's the thing on where I'm gonna start. You ready? You got your mic in your hand? See, okay, so let me tell you the other piece of the story. This is why they're all looking a little scared. Like, normally when you come to these things, all of these people have been super prepped, right? They've been given information about, here are the 5 questions I'm gonna leave you with, here are the things you should know, and you've got 5 hours to prepare, so there's an actual response. I didn't do that. Because I'm like, you guys know what you're doing, right? So we're about to find out. Here's my question. I have a couple of core beliefs. All right? Core belief 1. Medically assisted treatment providers, buprenorphine, Suboxone, methadone. I believe that the 20 to 25% of HIV cases, the 50% of hepatitis C cases that we say we can't find in this country are either coming through those clinics, adjacent to those clinics, and I say, the way I like to say it is this way, is that they are connected to their social, sexual, spiritual, familial, or drug-using network. My question for you is, am I right in my thinking? Well, you just ate, so you might want to give it to me. And, or, am I wrong in my thinking? If I'm right, how do we bring those people into the continuum of care, treatment, cure, and prevention? All right? So introduce yourself a little bit. Don't talk a lot. You know how you do. Don't do a whole bunch. Right? Tell the people who you are, so in case this gets on the TV, your mama keep it right. No, it's not with you. You got the biggest job on the
So,
stage.
Francisco Ruiz, I am formally the ONAP Director of the Office of National Youth Policy. My last day was January 2nd. We're still doing some of the work, but I transitioned to CDC. So here in Atlanta, I spent 9 years working in Atlanta, and before that, walking the streets with Tony. I think to your question around, and into the sort of the spirit of this, just also want to acknowledge that we're in this space, and we're in sort of a place of transition, the eve of transition, and I think this work it needs to continue regardless of who's in the Oval Office. And so I have had an honor to work within the Biden-Harris administration, and I look forward to working with the next administration. And I think this work, as you all know, is more than just a pill or a shot. It's about the whole person. Some of these require more than just medical appointments, right? So we have to talk about substance use and what does that look like? Talk about mental health, the stigma and discrimination that all that comes with, right? So we talk about the layered stigma that folks face and discrimination. And so as providers, as advocates, as federal employees, we need to make sure that we're providing services that address. So I think, to sort of answer your question, I think yes and. I think we need to make sure that we're reaching those communities and that those that are reaching them look like them, right? That we have, a lot of times in this work, we focus in on the alphabets. Daniel just got some new alphabets recently. I'm working on mine. In terms of these degrees are important, right? But it's really important to make sure that we center the people. And so making sure that we have them not only in our organizations, but in leadership positions, right? It's not just about bringing them because, oh, you look like our community, but what can we do to elevate them and build that capacity? And I think that's our reach community. When we have people that look like them, who have shared experiences, lived experiences, I think that's one of the solutions to make sure that people reflect. People are policy. We need to make sure that our policies look like, and our workforce looks like the community we're trying to serve.
I'll pick up where Francisco left off. It's bringing I'm sorry. I'm Daniel Drippin, here for now. I am an external relations manager with the HIV Vaccine Trials Network. We are the largest clinical trial unit across the globe investigating a preventative vaccine for HIV. We also did a lot of work with the COVID vaccine over the COVID years. We did all of the efficacy studies. So we're really good researchers. Thinking of the answer, I totally agree that it starts with community. I think in the HIV world, we use nothing without us is about us, and nothing is for us. And it's really starting at that intersection of Main Street and Cypress, Cypress in a way, huh? But anyway, it's bringing those people who have been invested for years, teaching them what you need to teach them and having them translate these messages. I don't think enough of these conversations that we're having today in this beautiful location goes to those key communities. And community has been saving themselves from day one. So it's really think about how do we reinvest not only education, but definitely resources to see those solutions and bring them to other places and adapt them accordingly.
Patrick Sullivan, Emory University, and I agree with. Hi, Patrick Sullivan, Emory University. I agree with what's been said. I have an additional perspective, which is, I worked at CDC for a total, I think, 14 years. I worked at VTN for a little while before landing at Emory. So I got to spend time with the rich, on the rich data side of things. And the thing that I'll offer is that I think sometimes as providers and as people who work in community-based organizations, and I've volunteered, in community-based organizations doing this work, so you have a person in front of you. If you zoom out a little bit and you take a look at what the patterns are, that really the impact of hepatitis C, of HIV, I really like your analogy about how these things are linked together. But so I think about this as the places, the people, the practices, the policies. And so the places, like a lot of places in the South, including the rural South, that are heavily impacted by HIV, are also co-impacted by STI epidemics, by HCV. And it really leads us to the conclusion that although we interact with people and we want to improve the health of people, we have to think about intervening at the level of these systems. And why is it that this happens in the South? Policies such as like Medicaid expansion, for example, is a really big driver of why multiple of these health problems spring up together. And so on the one hand, it feels like, you know, when we started this conversation, we were thinking about how we serve the needs of this person who's in front of us with needs, and we end up with a discussion about a lot of policy needs and historical racism and how that plays out for populations. But on the other hand, I think if we look at the roots of those weeds, the access to healthcare and the structural aspects of racism, transportation, where facilities are located, the good news is if we intervene at the same time at some of those roots, we have the potential to improve access to multiple kinds of health services. So I really want to think about like what we call syndemic, but it really is a layered sort of cumulative exposure to economic segregation, to racism, to sexism, and to a lot of things that have been around for a long time, and this is one of the manifestations.
Does this work? Yeah. Hi, I'm Alice Asher. I'm a senior health scientist in the Division of Overdose at CDC, and I lead our harm reduction unit. Overdose is not listed as a syndemic, but it is, obviously. And, you know, I don't know necessarily that all those people that you mentioned are coming through seeking medications for opioid use disorder, but they are interacting with the system one way or another. I think about an MMWR, which for those of you who don't know, it's one of CDC's very prestigious journals. And about 6 years ago, there was an article published from your colleagues in West Virginia after there had been a slate of overdoses. I believe there were like 20 something in a single 24-hour period. And people from the health department went back and they looked at all what those folks had been doing over the past year and all of their interactions with the system. Folks are going to jail, they're seeking treatment, they're ending up at the ER, and yet we're not capturing them. People are still, they're dying of overdose, they're suffering from substance use disorder. And I think all the reasons that folks have mentioned already are so true. Stigma, I think sort of maybe is the cumulative of sort of what happens when you have these long histories of structural issues and barriers that keep people from seeking care, and you get people ashamed to seek care, and the way we treat people who use drugs and the way we look at substance use disorder in this country really compromises folks. And when then you put that on top of a regional area like Appalachia, where you already have populations who are far apart from each other, limited systems of care even that people can access, it just compounds those challenges. And I think that's why Appalachia has sort of became the crux, or the place that sort of became the representative of the worst of all of the opioid epidemic and everything that has come since.
Thanks. And so you bring up the MMWR, and I want to go back to it. And I'm going to go back a year before that, because I want to go back to the 220 most vulnerable counties in the United States of America, right? And I can't remember all of the variables, but I want to say it was a number of prescription overdose deaths. It was a rate of unemployment, et cetera, right? So West Virginia, for example, has 55 counties. 28 of West Virginia's 55 counties were on that list. I think something like 47 from Kentucky were on that list, and several others. Now, many people don't know that the Appalachia Regional Commission, or the Appalachia region as defined now, Appalachia actually goes much further up and is much broader than most people think of as defined by the Appalachia Regional Commission, right? It's more than these 423 counties. But the reason these counties were defined as such was based on the economy, the economics of the regions. If you add everything else, there's some of those economies are doing okay. We're talking about poverty as an indicator here, right? Where I'm going with this is this, and I'm just gonna call a thing, because I feel like we don't talk about some things that I wanna talk about today, which is why I didn't tell y'all. Because that's what I do. How am I gonna get Jim Bob and Mary Jo to a clinic, or to an event, or to something to have a conversation about HIV, hepatitis, or PrEP uptake when they're gonna go on a website, or they're gonna go to some piece of information and they never see themselves. They never see themselves as a part of the problem, so they don't see themselves as a part of the solution. And if I'm not a part of it, I'm not a part of it. What are you come talking to me for? Right? So one of the things that we want to do, for example, is that we want to do this massive testing event at a Tyler Children's concert, right? Because that's where the people I think that we can't reach are. But then when I reach them, if I open up the brochure, or if I go to the, Brian Paul, if I go to the ad for the corporation, they don't see themselves there, Jay Maurice. They don't see, no, don't worry, guys. They don't see themselves there. They don't see themselves reflected in the material. They don't see themselves reflected on the website. They don't see themselves reflected. So what I'm talking about is the rural white IBU who sees themselves not as a part of the epidemic, or not a part of the solution to these challenges. And if I can't say to them, you might be vulnerable here, so you should come get this test. You might be vulnerable here, so let me talk to you about PrEP. This might be a part of your social, sexual, spiritual, drug sharing network. Let me talk to you about this. Well, if I look around, I don't see myself in none of this. What's the solution, people? How am I gonna fix this? I got the community health worker part, I'm gonna be doing that. But now I got them, where am I sending them? Don't look on the phone.
I'll say one thing is that I think to your point about the materials, the brochures, the PSAs, whatever, right, the resources that are out there, I've seen some really good stuff out there, right? I think what happens oftentimes in this work is things are sort of, there's some silos that are built, there's some, things that's happening in this place is not getting sort of transferred over to other places. So I would love to see maybe some sort of repository of sort of great resources that have developed across, and that's, the federal government funds a lot of these, right? So it's not always coming out of CDC, for example, with the CDC logo, but we're funding organizations to do that work. I would love for us to collect all that information and have it as a resource, almost like a menu that people could actually, because so yes, I've seen a lot of stuff that does not look like community and does not sort of invite people in to the work. But I have seen some good stuff too.
I'm gonna push back for you on you for a second.
Come on.
Is that, I know, that's what we're here for, right? You ate, right? Okay. So, I mean, that's it, right? Is it how we define community, or is it who defines community?
I mean, it's both, yeah, exactly. It's a yes and. I think the thing about it is communities different, right, for different people, right? And in different places. And so these epidemics are not homogeneous, right, in different communities. And so that our response is to be very diverse as well. So I think it's both.
And I think you have to have a regional approach. You may not see those ads across a ticker tape walking through the Atlanta airport, but if there's an airport in Huntington, West Virginia, that's where those ads are. I think it's promoting something from inside of the community once it's created. I think of, these micro advertisements have been done across the nation. A lot of organizations were waiting to see Black men together with Black men when we thought about pre-exposure prophylaxis. We didn't see that on a national level, But folks in Kansas City, specifically Blackout, created a campaign. Folks in Chicago, the Black Caucus, created their own campaign. So
Right,
I
and I'm
think we have
gonna
to
push
create our own
back on you.
campaign.
If people don't believe that people in Appalachia have a problem, they're not funding a problem because they don't believe that there's a problem. I can give them the data on the problem. We have an outbreak of HIV in West Virginia. Half the people, how many people in this room know that there's an HIV outbreak in West Virginia? See, I mean, who knows that? Who knows that? Who knows that there's an outbreak in West Virginia? And you're gonna say the numbers are not proportionate to the numbers of
I'm
others.
gonna say that.
No, but you had the look on your face. And it's my part. You had the look on your face. And that's a part of my challenge. A part of my challenge is that I gotta get the people that are doing the work in Appalachia to say, A, this is a part of our problem too. A, and B, I gotta get the people on the other side. Do you know how many people are sick of hearing me walk into a room saying Appalachia these days?
I can't imagine.
They are so sick of hearing me say Appalachia that you know, I mean, not the interchange, but yeah, also there too. But it was also at the U.S. Conference on AIDS when Harold Phillips said, okay, Appalachia already. You know, but we worked hard to get the words Appalachia has a challenge in the new version of the National AIDS Strategy. That was critically important. Appalachia being in there is to show up again. Just show up. These people have been overlooked for so long. If I don't get the guy with the hat and the straw with some chew in his mouth with a bale of hay in the back, he doesn't or she doesn't see themselves in this. All right, I'm going to stop preaching.
I agree with what's been said, and there are these pieces of, how we represent and how materials are prepared so that people can see themselves and connect with information about the epidemics. I think another way to think about this is that our identities are important parts of ourselves, but in the end, they're also, in the context of health, they're markers sometimes for where we live, or the networks in which we live, or the services that may be available to us in our particular circumstance. So the other way to think about this is instead of, so I agree that people need to see their communities, need to see themselves living in communities where this is an issue. That I agree with. But whether the solution is trying to personalize to the extent that you say, well, gee, like I'm seeing or I'm hearing that like people in this neighborhood or in this part or the Appalachia is affected, so maybe that's also me and maybe I need to go. I think there's a lot to be done by training medical settings so that this is just introduced in a way that is part of healthcare, which it is. And the recommendation for screening is that people, adults should be screened for HIV. And I had I'll just share something a bit personal, which is I had a physician who's a gay man who cared for both me and my husband. He knew that I worked at CDC. And when I went in for care after the screening guidelines changed, he said, like, I need to talk to you about this because I know that there are new guidelines. And I know under those guidelines that there are certain kinds of testing, but I know you and I know Mark. And I said, didn't say like, I'm going to check your blood sugar, I'm going to check your cholesterol, I'm going to check you for HIV because CDC says that's what we need to do. And so in a way, there's a piece of depersonalizing this in a way that I don't need to see myself in whatever that call is. And I think we need to take some obligation in healthcare systems to providing these services in a way that don't single people out, call people out, or make this intersect with one or more of your identities, but just say like, this is the recommendation and we want to take care of your health. The other thing that I'll just put a little plug in for is that our colleagues at CDC are working with, Emory is kind of implementing a program for distributing HIV self-tests, which people could just order through the mail, Together Take Me Home or ttmh.org. And we're advertising them in a lot of places. And people can just get that test shipped to their house and screen themselves at home. And I think because a lot of people in our communities have problematic experiences in healthcare, and we may all see this from our own perspectives, that being able to take that test at home may empower some people to take a step that they would not want to take necessarily in a medical care setting. Some people want their doctor to do it, that's great, let's do that. But for other people, maybe being able to get to access that information, read talk to a counselor on the phone, do that test at home is a good first step. And one of the concerns is, well, if people test at home and they get a positive result, maybe they'll never get linked to care. But where we've systematically followed up with people who got kits, there may be a delay, but people tend to find their way into care. So I think this is a little bit about removing the responsibility from the person, putting more of it into the healthcare system, and giving people multiple ways to take this step so that they can choose what path is comfortable for them.
Yeah, I think yes to all of that. I think the data is really useful in that, for example, overdose data is going down nationally. That's wonderful. Except among certain populations, it's not at all. For example, Black African American men, it's actually going up. So we need to know that, so that we need to know how to go out there and reach the right people. In Appalachia, opioids actually aren't the most commonly used drugs anymore. It's stimulants. And that's a whole other thing, because what do we have to really offer people in terms of care in most settings, especially in Appalachia? So I think there's reaching the right people, but then offering them services that are possible. So mail order is in telehealth, or I think especially in places in rural America, Appalachia, huge opportunities that we need to leverage. We need more to do with stimulant use disorder, and we need to help people understand what resources exist. Because if you ask most people who use stimulants, they're gonna say nothing. And their use might look really different than we're used to when we're thinking about that typical drug user. It might not be daily. It very likely isn't injection drug use. There's a lot of polysubstance use. So it's identifying the right people. So in terms of, in the Division of Overdose, we have our large flagship program, Overdose Data to Action. And what we've asked our recipients to do, which is 49 states and 40 cities and counties with folks at highest risk of overdose, is to look at their data and identify those populations that are either underserved or disproportionately affected. And then figure out how to go in there. And what we always tell them is 99% of the time it's not the health department. It's not going to be the syringe services program that already exists. It's going to be finding the group that's already serving that community, that already speaks to them, that is culturally competent, that looks and talks and believes like they do, and then helping them provide the necessary services. Because when anybody is going into a community and just sort of saying, you have a problem, I'm here to help, you're missing so much of the nuance and what it takes to really offer people real care and support.
Right, and I think that that's one of the things that we try to do with our CHAMPS community health worker model, right? Is that I really think that, again, it's about addressing that issue, the challenge of people, because, for so long, people thought people wouldn't test with people that they know. They wouldn't test with people from their neighborhood. They wouldn't test with, and I'm like, that's just not true, right? And we now have a lot of data that tells us and shows us that that isn't true. People really want that familiarity. They want somebody who understands them. They want somebody, and I say that community health workers are old case managers on wheels. They should be able to tell you how to take a test, where you can go for care, but also where you can get a turkey at Thanksgiving. And I think that that's what we need to really make sure that we understand, that it's not as simple as just send them to the clinic, especially in so many rural communities, but also that we have an opportunity to impact local economies by giving people jobs. These are jobs, but that's the other piece of this is, can we pay for community health workers as a reimbursable skill? And we should do that across the United States, but there's not a uniform response. That's one of the things that we're working on a policy side. I'm going to come back to this about the 220 most vulnerable counties. Help me understand what I need to do to get Appalachia in front of the rest of the world as a problem. Not a problem in a deficit sort of mentality, but in a sense of need, right? Because what I'm talking about are probably some of the proudest people. Don't always like to ask for help. some of the folks that I work with on a regular basis, there's several perceptions about people that aren't necessarily true, or not necessarily accurate of who they are, or what they believe, and how they live. But it is true that there's a need. So how do I get the federal government, the academic community, Sally Hodder's doing great work, Lynn O'Connell's doing great work in this space, but how do I get other scientists, behavioral, basic scientists, to see that their need in Appalachia is great? And I'm looking at both the two of you, Dr. Sullivan, I'm sorry, Dr.
Well, I'll just say a few things. First of all, rural America makes up 15% of our country. That is no small amount. So I think I think a lot of folks in policy-making world and decision makers think of rural America as a very small sector, and that's just not true. One of the things, I've worked extensively in Appalachia. I came to CDC in the Division of Overdose right when the vulnerability assessment index was published, so spent a lot of time there. And one of the things that I saw that really made people move and want to work is actually framing the issue as a development issue. When you have a population that struggles with substance use, isn't getting health care, isn't healthy, they can't work. Industry can't come in because they can't be guaranteed that there's a workforce there. And so this is not how I want to frame things. I'm a harm reductionist. I want to come with heart. But when you're talking about really motivating people, unfortunately, it's economics that often talk. And there's so much opportunity in this sector, in this region, that's just untapped because of the lack of resources. So I think that's one way to sort of make that push. Even if a bunch of public health folks and social service folks, that's not how we want to frame it, it works.
Dr. Sullivan?
I'm just going to, reflect that I've been working on this sort of mapping of infectious diseases for decades now. And when we started doing maps with ASVU, we did state level maps. And so CDC had produced sort of black and white materials that had shadings, but the intensity of the color gave it another dimension. And when we moved to displaying county level data, the first time I saw it, I just sat and stared because I said what I thought I understood, having worked for a decade and a half at the Centers for Disease Control and Prevention about the epidemic, was not really what the epidemic was in the South. And I think that when you look at the county level map, like people who look at it for the first time, just like there's a lot to take in. And a lot of it is an understanding that the most intense, so yes, Atlanta is a bigger city and has more people living with HIV. Charleston is a bigger city and more people. But if you look at not the numbers, but the density, the concentration, that it's, across the Black Belt of Mississippi, of Alabama, of Southern Georgia. It's in more, what we might think of as more rural, areas of West Virginia. And it's endemic, meaning that it's not just HIV, it's not just HCV, it's also STIs, it's also, other infectious and non-infectious health conditions. And so I feel like there's a way to one, use visuals rather than words, and to think about ourselves as communities, as members of the communities, where we live and work and play, and about the health of people in our communities. So if I live in a county in Atlanta, which is one of those intense areas, or a county in West Virginia, this is about me, regardless of how I see my personal risk. So I think trying to think about this as our communities rather than as a series of individual risks. And there is so much stigma around HIV. I think there's stigma around HCV. There's stigma around poverty. There's stigma around some of the behaviors that may modify risks of infectious diseases. But if we can pull this back a little bit and not focus so much on, who has this and who has that, but say that to have a good workforce, we need to take care of people's health. And there's a lot that's wrapped into that. And so I think understanding that policymakers, that community members are going to take things in different ways. I think we need to tell this story in different ways. And I think we need to break up some of the misconceptions or the easy ways of thinking about what this epidemic is and where it is. And I think maps are one way to do that. And then let's just like frame this in terms of what we need to do to take care of the health of our communities and think about the people we need to reach, as opposed to saying like, what's our HIV strategy? Let's just say, what are the communities who are going to benefit from this cluster of health services? And it's probably more efficient to take in multiple of these services in a package than to have somebody who says like, I'm the HIV woman, I'm here to do my thing. And then let's have the STD person come along later. So those are just some ideas about reframing how we think about the statistics and thinking about these as needs of communities.
And I think the stories matter, you know, so I know for me, I made the switch of taking a daily pill to the injectable 3 years ago. And every 8 weeks, I take a picture of the 2 shots that I, you know, get injected for my HIV treatment. And literally for the next week and a half, I have anywhere from 10 to 15 conversations with folks across the Deep South, across the Northeast, across the West, on what is it like, do I have any side effects, would I recommend it, you know? And I really haven't seen any of those types of conversations at the national level. You know, I think when we truly think about people living with HIV or any, you know, chronic illness, if we really tap into that market and have them talk about their true lived experiences, I definitely think we will see folks coming back to care, you know? I think we will see folks beginning a new prevention option. You know, I think about the Take Us Home test. You know, the MMWR said close to a quarter, so 1 out of 4 folks who requested this HIV test to be sent home, that was their first time testing. You know, so if we truly, you know, build opportunities like that and layer on the syndemic responses to STI, HIV test kit that gets sent home, I think we will have a new conversation that we are just at the scratching edge to it.
Well, how often, I mean, seriously, you know, again, that's why I don't give y'all questions in advance. How often are we really in a conversation with other people and not in a room talking to ourselves? Right? And what do I mean by that? That you're saying, let's have a conversation about what these home test kits will do. 1 in 4 people, this is the first time that they've tested. How often are we in a room where 50% or 100% of the room aren't HIV or public health professionals, but they're rural health folks? Because I mean, I got the people from this county over here. How many conversations, I'm gonna ask y'all, and you can go like, I didn't sign up for this part-time. How many conversations do y'all go in where HIV or public HIV hepatitis is the topic? And where are y'all from? Tell the people where y'all are from.
We represent the Appalachian Regional Commission program for the state of Georgia. I live in rural northwest Georgia in Murray County, and then my counterpart lives in Athens, Georgia.
Right, and I'm not picking on you. I'm using you as the example of, I gotta figure this out, right? I gotta figure out how I get them, more of them, because thank you for being here, by the way. I've got to figure out how I get more of them in a room with more of you, and more of you in rooms with more of them. Because if I don't get the 2 of you in the same room, you keep talking to you, and they keep going, I mean, not to you, that's not what you did, that's why you're here, I understand. But do you see what I'm saying? So tell me the solution to that. Where are the spaces that we need to be going into that aren't our spaces? And that we are saying, hey, we're coming to share information. Now, we're coming to educate you about the HIV. But we're coming to share with you because we know that you need to have this piece of information for the communities that you serve. Francisco, you look like you picked up the line.
Yeah, that's exactly sort of what you're saying is like getting out of our bubble, right? Oftentimes we speak to each other, to your point, right? And I think there's a lot of importance of having that shared space so we can learn from each other, folks who are doing this work. A lot of sort of solidarity building and sort of that kind of thing. So I don't want to mitigate or minimize that, the importance of that, right? Because I think we can always continue to learn. There's always great examples that I take on when I hear a colleague who's working in HIV. How can I adapt that for my community and the work that I'm doing? So that's still important. But I think to your point is breaking out of that HIV bubble and making sure that we go to those spaces. I think a lot of times we talk about that in service delivery. We talk about, mobile clinics, getting into communities, leveraging pharmacists, and sort of going to places and making sure the information is there. I think that's really, really important. We don't often talk about how we do that with policy, right? We never talk about how do we sort of walk side to side with folks who are pushing immigration issues, transgender, LGBTQ plus issues, reproductive justice. And so, being in DC, as many of you know, DC, every other building is some coalition of so-and-so and so. There's so many groups out there. How do we come together so it's not just Francisco walking into that room talking about HIV, Tony walking into that room and talking about, right? Like, how do we all come together so we can share a script together? And how do I bring the message about reproductive justice and other things? I think so that it's going to those spaces, and that is going to involve us doing the work, doing that research. What other issues are important? How do I bring in? Because if you want them to talk about HIV, you're going to have to also talk about those issues. So part of it is also teaching yourself about these other issues and how does it all come together. So in this role that I was in at the White House, we have the National HIV Strategy. And part of that strategy is a whole of government approach. So usually in HIV, we talk with HHS, right? We talk to CDC, CMS, more and more now. Center for Disease Control and Prevention. HHS is the Health and Human Services. We also work a lot with SAMHSA, the Center for Medicare and Medicaid Services, NIH, National Institutes of Health. You can say there's a lot of
The Substance Abuse Mental Health Services.
SAMHSA.
I know what you meant though.
We got a lot of acronyms in government, as many of you know. So there's a lot of health agencies that we work with, right, across the government. But we oftentimes don't talk to the Department of Labor or Department of Justice, Department of Education. And so these are also things that I was trying to build in those relationships to make sure that they also talk about HIV. How is housing HIV prevention and treatment, right? How is education and economic mobility HIV prevention and treatment? And so I think we need to do that work and sort of bring that sort of other arm and do the work and go to those spaces as well.
And the Appalachian Regional Commission, which is a federal agency, which is why we asked the federal co-chair to come to the PACHA meeting in Charleston, because there needed to be an engagement between the ARC and the PACHA meeting. And it was like really one of the first times that there had been that sort of connectivity. The ARC is sitting there. It represents 26 million people. And the Department of Health and Human Services is not calling them saying, hey, we need to have a conversation with you about health outcomes.
And the thing is, it's not just about inviting to the meeting, right? That's a cute first step. What is the follow-up afterwards? Right? And so you can't just go to a meeting, show up, put your agenda, your other work that you're doing, and then walk away. There needs to be that back and forth. And so that, having them come to PACHA is great. And then what's the follow-up? And I know that's hard, right? Because we're all busy. We're handling already carrying our own buckets of the work that we're trying to do. I don't have any more room in my bucket to put anything else. And so that's what we need to think about. How do we lean into each other and help carry each other's buckets?
You get a bigger bucket.
Right.
Yeah, and I think mutual aid and community building are a lot of what lead to that. So especially in places like Appalachia, again, where there's not a ton of resources, if you get organizations together and one's providing HIV service and one's providing financial support and one's dealing with childcare issues, you can start to address what folks really need, which is solutions to some of the basic problems so that they can start thinking about some of their competing issues. There was a project, this is quite a while ago, that was funded at CDC in our in our Division of Adolescent and School Health, but I really loved what they looked at what was going on with youth in Appalachia and saw that there was had been a dissolution of centralized community in the area. And so what they did is they started a program that really looked at the front porch and looked at where people were gathering, where conversations were happening. And they started to do some work around like, how can you take that and rebuild community by rebuilding the front porch, getting people together where they're just sharing their experiences and able to help. In overdose, about 50% of all overdose deaths happen when people are using alone. And that's a huge challenge. And we have some technological interventions that we can use, and there's some things that we can do, but one of the things that I'm seeing some places do, San Francisco is doing this, but is community building. So people who live in single room occupancy hotels, there's a lot of people around, but they're not interacting. And so they're starting programs where they have champions in the community who are bringing people together and educating them and saying, hey, if you're gonna use, tell me, leave your door a little bit open so I can look in there and help. Tell me where you're keeping your naloxone. And these are just little things, but I think when you can start to sort of build those connections between folks and between agencies, and sort of create that mutual support, then you can start to address some of these larger problems and get to some of those issues that you brought up.
I just want to say something that might be obvious, but the folks who are actually providing other services and who have staff who are in communities are trusted sources. And I wonder if there are quieter ways to integrate with some programs that may exist with self-test kit distribution, with naloxone distribution, just to build on existing, helping relationships and place some of those just commodities. I mean, folks will take steps that they feel like are going to benefit their health. And a lot of people don't know that HIV testing would be recommended for them. And so it might be a way to place some of these, commodities along with other supplies or other, kinds of assistance that are provided from trusted folks. And it might start a conversation. Why are you giving me this? Oh, like everybody in the United States, should be tested for one time, and this way you can do it by yourself. So I wonder if there are other points at which we can leave some of these commodities with trusted spaces. And I don't want to minimize that. We want to put work onto groups that are maybe funded to do something else, but we should see these as opportunities. And because of the stigma associated with testing, because it can be hard even to bring that up, because people say, why are you asking me? And then it leads to a conversation about, well, everybody in the U.S. Should be tested at least once in their lifetime, and so that might be an opportunity. But I think where those relationships exist, there may be sort of low impact ways to just make more of the commodities available. And if someone in my family tests and I see that may also start a conversation.
Well, I think about this weekend, it's winter.
Oh, sorry, I thought you talking about something else. Go ahead, sorry.
I think that this here in Atlanta, it's like winter pride season, and thinking about the tens of thousands of folks who will come to the Atlanta metropolitan area, and think what it looked like to just have nondescript kids sitting in the bathroom at Parksville Jackson, or nondescript kids sitting in the bathroom at your favorite brunch spot this upcoming weekend, filled with everything you need to either, be a little bit healthier when you go home on Monday or Tuesday night, but no one is doing that yet.
Okay.
Or not enough of it is being done.
So you are hitting the nail on the proverbial head, sir, doctor. Because the thing is that I'd love to do that, but I'd also love to do that at a Child Children's concert. Except I gotta educate them about what that kit is and what that value is. You have a different population that is gonna have some connection to what that is, what that prevention strategy is, what those things are, I've got to do a whole different leap for this other population and this other community. Yes?
Can I ask you a question?
You can
Is that
ask
part
me
of the
anything
format?
you
Yeah.
want to, other than for money.
So, are there places where HCV testing has been more, where that, some of that work has been done around HCV testing and where that's more accepted? And could that be used as a bridge to say, you know, folks who would benefit from testing for HCV would benefit from testing for HIV at the same time? So are there, and I think there are some like less, ways that might feel less stigmatizing, just given the stigma around both of these infectious diseases. But I think HIV has a long history of different types of stigma and shame. So are there opportunities to sort of package it up and say, since you're here for HCV, like this goes along?
And I think that this is what we're trying to do with MAP providers, and I want to do with MAP providers in the region, right? Many, so depending on what state they're in, there may be a mandate that they screen for HIV or hepatitis C when you come in, but there's also an opt-out provision. If I don't see myself as a part of the challenge, right? If I don't see myself as a part of HIV continuum or Hep C continuum, I say, I don't really need that HIV test or that Hep C test. And so the provider says, you're right, you don't, okay, you said, no, I don't want it. So what we've got to do is actually remember that we're talking, remember that train I talked about earlier? That train that's rolling through Appalachia, that infrastructure is based on the opioid crisis. For 30 years, we've been dealing with HIV, those of us here, right? We're not the opioid crisis in the same way. For 30 years, the Appalachia region has been dealing with the opioid crisis. So that's been the priority. That's been the thing that's got the infrastructure built around it. That Hep C continuum that you're asking about is actually how I got started, right? I got started because I called somebody in West Virginia, and I'm not going to name any names or no departments, but when I was sitting there, and somebody sent me the 220 most vulnerable counties report. And I said, who's working on this? I called somebody at HHS, that's the Department of Health and Human Services. I called them and I said, hey, what are we going to do about this? Who's doing something? She said, nobody. I said, that can't be true. This is a real problem. 28 of the 55 counties are impacted. She said, I get it. And I said, well, where's the money? She said, there's no money. And then guess what I did? I called, I'm not gonna tell you what health department, I'm not gonna tell you who. And I said, hey, can I get your surveillance report on hepatitis C? And you know what they said? What's that? And I said, what do you mean, what's that? I said, aren't you the person in charge of hepatitis? And they said, mm-hmm. And I said, well, don't you know what the surveillance report is? Is it, maybe that's not me. And I said, uh-oh. And I said, we got a problem. And so then guess what I said? I said, hang on a sec. It's on the front page of your website. Thank you very much. Have a good day. And I said, oh, by the way, what do you do? I can give you a poster. I can give you a brochure to tell you how not to get hepatitis C. Okay, thanks. So what I'm saying is that I don't begrudge the people who don't get this HIV thing. Because there's a couple of things. Number one, they're tired. They're exhausted. They're exhausted with the opioid crisis, and we haven't really kind of unpacked that. We haven't unpacked the state legislators that are tired. We haven't unpacked that. If you look around the South, if you look around Appalachia and you look at state houses and you say, well, how could they introduce or pass X bill? Right? I'm sorry, I just have a core belief, and these are mine, is that people are tired. But I also believe that these members of state houses who are in positions in local and county government have also for 30 years dealt with an opioid crisis in a very personal way. You can't tell me that they have not been impacted at some level of trauma of their own, that they have not had a family member, a friend, a mama, a daddy, a cousin, a nephew, a person that they went to high school with, that they've had to address this issue with them in their social, sexual, familial network. The challenge now is that I'm now having to come back 30 years later and say, oh, by the by, I need you to help me with this HIV thing, this hepatitis C thing, this unemployment thing, and, you know, I know you went through that COVID thing too, but now I need you to keep on going. I need you to keep on going. And now we're gonna talk about, and I'm weaving myself right into my next question. Because now I got all of this opioid abatement money coming too. And for those of you that don't know, that's the opioid settlement money. They call it opioid abatement in the policy world and all that. But I know most of y'all know it as opioid settlement dollars. That's what I call them. Yes, ma'am. What's the opioid settlement money?
No, it wasn't about that. I was just gonna make a suggestion. You were saying, how could we get more people come up to the?
We coming to the solution in 2 minutes. I'm gonna ask this opioid settlement question, and then I'm getting ready to open it up, because I got a killer question for the end. For the end. I know they're thinking, this isn't the bad part. All right? So tell me how I'm gonna get the opioid, you know what I wanna do with the mapping on the opioid settlement money. You already know that. But how do we get the opioid abatement people to talk to these people and the syndemic people? Because the syndemic people and the opioid abatement people gotta be the people that are gonna pay for all of this. Because most of these health departments don't have any money to pay for this. But they do have it in these opioid abatement dollars. But they don't know that this is a part of the solution. Help me, help them, help them. Help me, help me, help me, help me. I need some help. Help.
I think, I'll say again that like maps are worth 100 tables. And I would just say historically that the kinds of information that comes from public health surveillance systems, that comes from, screening, have been used as the basis for allocation of HIV dollars for all kinds of public health problems. And so I think given a pot of money and given the need, that would be a way to really bring people in, to sort of say, like, let's look and see what, the jurisdiction you represent looks like in terms of this epidemic. And, I think there's a menu of programs and use of money, many of which have been talked about, that would be appropriate uses for that. And I think it needs to be allocated in proportion to where the need is. So I would say, maps are sort of a common language and a common way for people to sit down who may have a programmatic perspective, a clinical perspective, a financial, disbursement perspective, and maybe agree on what some areas of focus would be. Another way to think about this is to say, if we want to roll out programs and we can't do it like flipping on a switch, let's pick some of those most heavily impacted areas as the sort of first round of places based on impact, and learn some of the lessons there in the places that are going to have the most impact.
Hey, Lee, could you come here a second?
Can I jump in really quick?
Yeah, absolutely.
So I think a couple of things. Opioid abatement money is an incredible opportunity. Huge, huge sums of money that we have not seen that are available to states and localities. The people making decisions about how that money is spent varies widely from jurisdiction to jurisdiction. It's frequently not your public health folks. So one of the things we're working on is trying to help bridge those connections, making sure that the people with the experience and the expertise are at the table with the people who are deciding how that money is getting spent. We are also trying to take, we've talked about all these incredible resources that CDC, that Emory, that everybody's made over the years. A lot of it's made for other public health folks. And so one of the things we're trying to do is take a lot of that work and make it for policymakers, speak in their language, make it very short, very sweet, very to the point, so that, again, the folks who are making the decisions in so many places aren't public health people. And a lot of times they're like, their friend suggests something like, oh, that's a good idea. There is nothing stopping them from putting millions and millions into something, regardless of whether there's any evidence behind it. One group that we haven't touched upon enough today, I think, is the public safety sector. Again, when folks aren't interacting with the healthcare system, they almost certainly are interacting with our EMTs and our law enforcement and our courts. And so there is huge opportunity to really do a lot of education, a lot of bridging. We are right now at this really, I think the last election cycle showed us a lot that there is certain places are really moving away from more of a compassionate approach to people who use drugs to something that looks more like criminalization. And so what can we do with opioid abatement money, with bridging public health, public safety, and policymakers, and really trying to get together to address some of these systems? Because going back to your first question, people are interacting somewhere in that system. And so how can we get everybody on the same page in trying to do this work together in ways that's evidence-based, and that's really what works for folks and not just what sounds good.
I'm gonna ask Representative Cooper, because you're our only elected in the room. Tell us what you think we should be saying to those electeds.
Well, first of all, I think one of the best things you could do is not by county, but by district. Pinpoint into our district how much syphilis, how many cases of HIV, because there's a lot of denial that goes on. Most legislatures are still pretty heavily male, and I think there's a lot of denial, and I don't want to think about this kind of program. So I would suggest, and we have just got one from CHOA, the Children's Hospital here in Atlanta, telling me exactly how many visits the children in my district have made to CHOA, and all sorts of information like that, which is very specific. That would be a help. And the other thing I wanted to say is, when you're talking about it, years ago, I was really honored to be on the President's 30-member Violence Against Women Commission. And I served with a lady who was a vice chair of Avon. And one of the things that they did, you want to get the message out? They taught all of their Avon ladies how to recognize domestic violence. And they talked to people as they went out and sold the products. It was hugely successful. So there's lots of ways to get the message out to reach people in their communities if you just think a little bit outside the box. Tony, thank you for letting me be here. But yeah, I am the only one, and I had the honor of going to the summit in West Virginia. If you haven't been, I would suggest you by hook or crook get there. It was wonderful, and I was the only legislator there too. Do a little work before, tell them where they're going. It's a beautiful state, in the summer. They can spend their campaign funds, at least in Georgia, to get there. And it's well worth the time. But meet your legislator. No matter whether they're Republican or Democrat, whether they're not from your party, it doesn't matter. This is healthcare, and they need to know you and know your face, and just always be nice. You get more effect with honey than you do vinegar, and but you got to do some more with them too. Thank you. I look forward to seeing you again. Thanks for coming to our state.
All right, thank you. I'll see you in Huntington this year. Perfect. Thank you so much. Thank you for joining. All right.
I've got to be back again.
All right. Thank you so much. You had a.
Yeah, so what I was going to say is, in addition to working on that night when I'm not in front of my work computer, on my personal laptop at school, in my doctoral project, I'm actually focusing on grading funds. And I think to your, I was getting the doctor. Thank you, though. And so grading fund essentially is when you use multiple funding sources to implement a program or to look at a system of delivery, right? And so I'm working on that from a systemic approach. And it's very challenging. It's very regulatory issues. There's constraints of how we can use what kind of funding for what. But there are opportunities and there are examples out there. That's sort of what I'm looking to uncover. And so I think that, to your point, is thinking about a lot of times this work is very siloed in the funding. So here's your COVID money, here's your hepatitis money, here's your HIV money. And a lot of times those funding streams have sort of, the rules and regulations that you have to abide by. So I'm not saying not to do that. But when you braid, you could still look at how you're using, where the money's coming from. But you're able to sort of braid it in the fact that you could get a program in place that serves the whole person, right? So we talk about a whole person care. So this is sort of like a model that is like a whole person funding. And so when you have your opioid money, you have your HIV money, you have your STI money, figuring out ways to help support outreach workers, your community health workers. There are different ways that I've been sort of trying to see different models, and I'm hoping to graduate with something to be able to publish and share with everybody, but also to use it as a resource for not only for CDC, because that's sort of what is my host organization for this project, but really how we do that at the community level, right? As recipients of getting funding from the Centers for Disease Control and Prevention, from Substance Abuse and Mental Health Services Administration, where you get funding from all these different federal agencies. How do you then, as an organization, as a clinic, use that and implement a program that pulls in different resources? And there are models out there, so I think that's what I would say, looking at that. Whereas blending is when you put everything in a pot and you kind of lose track of where money's coming from, right? We know that oftentimes has a little bit more of a challenge when you have to sort of speak back to your grantor, like, hey, this is where this money is used. Braiding is a better option in that you can see that from what I've been doing with my interviews.
Okay, so braided funding. All right, so we have about 10 minutes left. I'm gonna take another 5, even though they don't know it. Because that's what it's my party. We're gonna close on this because we're gonna bring in people for a conversation. Dr. Driffin and I were having a conversation the other night.
I did not sign any.
Conversation. And what the conversation was not that one, was when and how could we end AIDS, HIV in America? Now, I used to always use the number given to me by Dr. David Holtgrave back in the day of what the number was. But we were discussing this the other night, and we believe that even in, no matter the political time, even in this political time, with a $2 billion investment, that's what we said. Am I right? Am I wrong? A $2 billion investment, that we believed that you could end HIV by 2047. 2047, it's 2025 now. But look, so that Sullivan went, and he's like, no, you can't. No, you can't. Let me math that man. No, you can't. Now, I think it would take a little bit longer, but the logic be that, for those of you in the room who don't know, there's a company that's coming on the market with a product that we believe will be able to give you 2 doses. One, and every 6 months, would be able to treat HIV, right? So for people living with HIV, you get the shot twice a year, and you would be undetectable and untransmittable. Bam. The same company also has a product that if you take it, in 12 weeks, you could be treated and cured for hepatitis C. There's another company that currently has a product on the market now that, how many doses do you get with the V product?
Treatment is two drugs every 8 weeks.
2 every 8 weeks. So the same company would be able to give you 2 shots a year to prevent HIV. So if you're not living with HIV, you could take these shots twice a year and you could not get HIV. And we're not going to talk about whether or not they're up or down on STIs. That's a different can of worms for a different day. We're talking about the ending of HIV. Round robin question for everybody in the room. 1, raise your hand if you believe that we can end HIV across the globe is what we said. We just, now you changed your mind, my friend. Oh no, my friend. I don't drink, so I remember the conversation. So, okay, so you're now taking your number back to me, a domestic response?
So, yeah, I was answering.
Domestic,
Yeah, like-
okay, all right, I'll even give it to you then, okay, all right, okay. But okay, so how many of you believe with a $2 billion investment that we could end HIV domestically, meaning in the United States and our territories, by 2040?
Question.
Yes, go ahead.
When you say end HIV, can you spell that out for me a little bit? But I'm channeling my
END.
doctor. Griffin.
Okay.
Griffin.
Go
What
ahead.
does end HIV mean to you?
Ending HIV to me means that anyone who is living with HIV, has access to treatment and is on treatment. Anyone who is in sexual behavior has a preventative mechanism available to them and is accessing that preventative mechanism. And that new cases of HIV have dropped below 1%.
It's 1%.
Well, that's the end, my friend. Zero is, I think, next to impossible. I think it's a 1% is where my end is. Look, Dr. Sullivan's like, why is she asking us why? This is impossible. This is impossible. That's why I don't call Tony back.
The reason why I asked that question is when we talk about ending HIV epidemic, a lot of people living with HIV take that differently, right? And so I think it's very important to name it, that we're not talking about erasure. People living with HIV are still going to be here.
Correct.
They still need the care, and it's more, as we talked about, it's more than just the pill of the shot, right? We still got that stigma thing, discrimination thing that we need to address. So there are other things beyond just the medical side of it that I want us all to take into account.
Okay.
So that's why I was asking what you meant by that. I don't know if yours was the same as.
No, what was your
definition?
My definition was a little bit different. So again, I think it's many of those aspects. I think, the 1% is really aspirational. I think I would.
That's my job, man.
Yeah.
To make people believe.
Yeah, I think I would have it just a little bit higher. But again, it has to be a local response, and I think about, rather than like building from the top down, I really think we have to flip it and go from the bottom up. So I think about the fact that we are sitting in Atlanta. Any given time, we have roughly 2,400 people who are not undetectable, okay? Specifically, our Ryan White Part A program takes care of 18,000 people living with HIV through a federal program. Like right now, we have 2,400 people who has a viral load of more than 1,000, okay? 67% are male, Black, in between the ages of 19 and 34.
That's a young group.
It's a young group. And we have more than 13 organizations that actually receive resources to get these people healthier, And we are not having, I don't even think we need out of the box conversations. I just think we need a basic conversation of creating some version of a triage to really weave through who are the folks that you've touched over the last 6 months, 12 months, 18 months. How do we get them to someplace other for care? Because maybe they're not coming to agency X because you othered them on some reason, but how do we get them to someplace else for them to restart that conversation? I think for me, the end is really looking at the number, since we truly have a denominator of people living with HIV, and we know how many people are out of care or consistently in care. So let's start there versus, going through the thought exercise from the other way around. The individuals who are vulnerable to a diagnosis. I think my end looks from that side. But it's a conversation.
And you did say it was, but Dr. Sullivan, let's move on. Dr. Sullivan, did you have an answer?
No, go ahead.
No, I want you to tell me how we're gonna end it by 2047.
Oh. You know, I think the piece that I'll add, which I'm not sure is a complete answer, but is an issue about where we need to focus, is that I think that the idea of synchronicity is going to be what complicates this. Because you can make a spreadsheet and say, we got this many people, we need this many drugs, we need to do that, and everybody's going to be undetectable, and it's going to be have PrEP protection. And I think we have to put systems in place that should be the lowest possible barrier, you know, for people, especially if this is twice a year. You know, I look at funds to say, where do you want to get your injection? You want me to come to your house? You want me to come to your work? Like, how do you want to do it? But I also think that there is sort of a 90-10 kind of rule that applies, that there are going to be a set of people that if you make those resources available and make it easier, it'll be fine. And as it's been since the beginning of the epidemic with prevention, there's a set of folks who, because of other kinds of syndemics, of racism, of urban deserts, of poor transportation systems, I would say in that scenario, plan on investing 70% of your money in 10% of, or 50, I'm not sure what it is, but it's some, you know, small percent. And just recognizing that equity is not about saying everybody, if they come to their clinic between 9 and 5, is allowed to get an injection that will suppress their viral load for 6 months. And we're making that available to everyone, so there's an equitable solution. Equitable is understanding who is going to need the visiting nurse to come out to their house and provide that because of the other challenges. And so I think it's starting out with an understanding that you can build some good public health systems, but we're going to need to concentrate resources in people, and because of the same syndemic factors, because of the lack of approximate HIV prevention services and the difficulty with copays and the competing priorities and concurrent substance use, you know, have a harder time accessing prevention are going to be the same ones who need more support. So I would just go in clear-eyed that we're going to have an equity-based solution. I think if you have an access for all equality-based solution, you will fail and you will make the disparities worse by race, ethnicity. The South will get worse relative to the rest of the country, and we run the risk of decreasing the number of new infections, but concentrating them in the communities that are already hard hit. I'm sorry, that's not very, I'm supposed to be positive and optimistic.
Yeah, you were.
I'm saying if you want to do it,
Yeah.
understand it's going to be a pyramid with a lot of the resources in the 10 to 15% of the people who have a lot of other you know, challenges placed upon them.
But if we braid the funding,
I'm-
but if we braid the funding, no, just kidding.
Then you get like 50% of each of the braids to that, because they really are the same. They really are the same systemic societal issues and inequities that give rise to all of these health conditions in my opinion.
I am afraid I feel very much the same, that increasingly the folks who are at risk for any of the conditions that we've named are folks who are on the margins, who have not been successful when they've tried to interact with the system, when they've been failed by a lot of people, when there's other issues, competing priorities. Our legislator earlier mentioned women, people with families. There's just so many competing priorities, and I think we can make huge strides if we have all of these barriers addressed. But I think we just have to think really hard about how do we reach folks in an age of marginalization, of separation, and of misinformation. Because frankly, I can just in my head right now, I'm just thinking about all the things people would say about these interventions and getting folks to really, who are at highest risk, to really believe that there is a government system here. I work for the government. I know what people think of me. Like, how do we get people to believe that we really want people to be healthy and taken care of, and we have their best interests, and here we are offering you services and keep coming back. And even if I could, I'm a nurse, even if I go to your home if you're unstably housed, do I know the 7 places that you might be able to sleep in, and your phone number is changing, and I mean, so I think we can do much better than we are. I really do. I think that both domestically and globally, I think we should always strive for ending the epidemic. I'm not sure we can do it in 20 years. I'm sorry.
I told you, Daniel. Yes, sir, in the back.
I want to speak on this so bad.
Okay.
My name's Riley. Don't have any.
Okay.
We saw the mic up front, too.
Riley, you hold up one second. I want to go with this woman here in the front. She had a question first.
Oh.
Yeah. Miss, I don't know your name.
Oh, I was gonna make a comment
Okay, yes, ma'am.
that you had spoken on about how to get your family and everybody else involved.
Yes, ma'am.
I would say, I'm thinking, by the way, I'm Sunshine Jordan with Emory Research. I'm thinking that, everybody that I know got some kind of illness going on in their family. As far as lupus, sickle cell anemia, cancer, that's a big, part too, as well as HIV and AIDS. So I would say at restaurants, beauty shops, cause that's what folks mostly come together at. Have people in those places as well as the ballpark, concerts, and have a section like you may give them, cause everybody like a discount or whatever. So I would say put up your booth, and if you come and get tested for one thing, you got to get the other, and let them know that you genuine concerned about their health. Your grandma, put that in there. Your grandma had high blood pressure; she could have still been here. So you get tested for all of this, and you getting a ticket, a reward, maybe $10 off of your meal, $15 off your hairstyle. But you reaching the community, I feel, as well as getting your information out there also. And go to the schools, go to where the young people hang out, at gyms, at lift weighting places, they like that, at the skating rings, bowling alleys. But we got to start somewhere.
And I think that that's one of the things we're trying to do is engage more community health workers to go out into those spaces, offer HIV, hepatitis C, and syphilis screening in those
Don't
spaces.
just stick to one step, but do all of them.
Yes, ma'am.
And I feel like grocery stores, because that's where people come to, and give them a little $25 gift card. If you can get 5 of your people to come, you just got to throw something catchy. Oh, yeah, and the homeless shelter too. I would say start there first.
Thank you, ma'am. Sir in the back?
Thank you. I apologize for getting excited there. So my name's Riley. I'm the executive director of Access Point of Georgia. We are a peer-led, community-based harm reduction program in Georgia, in Athens primarily. In Athens, but we serve folks from 30 counties. And I just there's a very humble part of me that when I started out doing this, what I'm learning and the things that I am seeing and know, and he's oh my goodness, it's not like this, it's really like this kind of thing. And speaking into the marginalized populations, and that the people who are truly needing services are not getting them, and service providers are not making it easier. And we intentionally deal with active, often very chaotic users, and I'm gonna hand them a card and say, go to this place on Thursday at 3. They don't know what day it is sometimes, But we got this old funky band, right? We had to build relationships. And we, from the testing that we do, which is very precarious, because we don't have much money for consistency. But the CSB, the Community Service Board in our area, did like, I wanna say 503 tests, HIV and Hep C. We did 11. The 503 had 0 handoffs, 0 linkages to care. And we had 3 out of those 11. But like that, and like that's the kind of stuff that has absolutely blown my mind. And then doing so many different things where I can learn how to navigate through certain communities that, there's so much community building, and I really, sometimes it's not that I dislike the word harm reduction, but like, it is all about connection. It is all about connection. And, I do believe that we can cure this. I do believe, but like, what are we gonna do with that $2 billion? Where is it gonna go? Are we gonna keep in like that? Those are the kind of questions and things that I think now. And I think, I'm just really into this whole magical, like, community-based, like these little mom and pop places, like, oh, you don't know how to do nothing but shoot dope and talk to your people, but you don't shoot dope anymore? Like, come on. Like, come on, let's build community. Let's like hold people and get people together. And it's a very different experience for the people that we serve. There's no power dynamics. There's no punitive measures. I could go on and on. I'm gonna stop, but excellent dialogue. And like, thank you for the question. And I think we all can really chew on this.
Perfect. Thank you, everybody. What I would like to do is, we're getting ready to close out, but the first thing I want to do is that on your table, there's a little card for a thing we call the Syndemic Summit. Last year was our first one, 30 years of an organization, and last year was the first year that we convened the conference. Lee, Lavina, Brandon, Glory wasn't on the team yet, but she's now on the team for the summit. I think Dr. Driffin was there. I don't think you couldn't bother to leave your White House office for your ivory tower to come to the hills of Appalachia, to the Greenbrier. We couldn't get you, and now you don't work there anymore. See, karma. So here's the thing. That we are going to actually have another Syndemic Summit in September. This year, we are gonna make it over 3 days. We had some feedback that told us that folks wanted it more time. And so we're hoping that you will come, but most importantly, we're hoping that you'll share this information with others. You'll have to save the date now. If you sign up for us, you'll be able to get information about when registration opens, when abstracts open, and who else we should be bringing. But I think a part of what you were talking about, what we were talking about today, is that one of the things that'll happen, I'm not supposed to say it publicly, but I'm going to do it anyway, because I've been known to do that. Everybody in my team just went, well, I'm going to do it anyway. Lee's like, please don't, but I'm gonna. So we believe that an organization that we think does some amazing work called Hope in the Hills, which sponsors another event called Healing Appalachia, will be moving in the area of Huntington, West Virginia. So we're going to be moving the summit from the Greenbrier to Huntington, West Virginia. Because in the evening, what they do is that they do a concert series, country western concert series. It is the charity of Tyler Childress, Country Western Star. And so over the course of 2 days, they do that for 2 days. There are over 20,000 people that come through those gates. And they are either people who are impacted by substance use disorder, social, sexual, familial connection that way. And what we want to be able to do is a couple of things. We want to be able to ask them those questions. Have you ever been offered a test before? Do you know where to go get a test if you want one? Would you like to take a test today? Would you like to take a test for HIV, viral hepatitis, for syphilis? Or would you like to talk to somebody about this thing called PrEP? And we have them being able to offer PrEP on demand. So we've been working on this network of providers that will be out there for the 2 days, and a network of over 200 community health workers is our goal, to get them out there in paid positions for the 2 days to be able to do that. So if you can't come to the summit, we hope you will. What we plan is that during the day, you'll have your didactic learning, is what we call it, didactic learning. That's what when the PhD is there. And in the evening, the entertainment of the Healing Appalachia. Now, why am I telling you all this? Because I want you to come. It's mostly going to be people from West Virginia, Ohio, Kentucky, Maryland, and Virginia. But I think it's something that you should see. I think it's a part of the experience we hope to have. Last year, we had representation from all 13 of the Appalachian states. We hope to do that again. We hope to broaden it. Last year, we had 350 people. And this year, I've tasked them with getting at least 1,000 people there. How many, Gloria? Don't look away now. How many people are supposed to be at the summit this year?
About 1,000.
And how much are you supposed to raise?
$2.5 million.
Thank you. So there you go. So people got jobs they got to do. So, you know, if you want to see her this time next year, register for the summit. Register for the summit. Register for the summit. But most, yes, ma'am.
We have a microphone.
Okay.
Just give us one.
Look. We have no more jobs at the community education.
Thank you, and thank you for this event. I am Natasha Taylor, Deputy Director of Georgia Watch, and we lead Georgia's Community Health Worker Advocacy Coalition. And I'm appreciating all the talk about community health workers here today. And we are excited that we have a legislation being introduced to create a state recognized certification for community health workers with strong leadership support going into this session. But to the point that has been made a number of times, and to the gentleman's point who spoke here, and we saw this with the pandemic, funding comes in during a crisis to employ community health workers because they know that they work. They know that the way you reach people is through people and through that community connectedness and that trust, right? If I'm getting my hair done, I'm like, girl, where you get your hair done? Like, that's how you find things out. It's not by a flyer or a billboard or someone you don't trust telling you to go somewhere to get some help, right? We know it's through community health workers, but then we have this funding come in and it's, yay, there's no more COVID. Now all the money goes away. So here in Georgia, we are wanting the state plan amendment to make community health workers reimbursable. I know this is happening at the national level, there's advocacy there, but for those in the room that can help support our efforts, we need the Department of Community Health to see the value in this workforce and create that state plan amendment, because what hurts my heart when I talk to community health workers across our state is that they're not worried about losing their jobs. They are worried about all the people that they help losing that trusted resource and that connectedness to care. So I just want to uplift that and say anyone in the room that can help, that can get behind us, that can support us. We are having Awareness Day at the Capitol on February 11th. So those that can make it there, the more support we can show. We have North Georgia, rural Georgia, South Georgia. Everybody is at the table saying, yes, we want this. The easier it makes our job to get this done. So thank you for this. I'm very honored to be in this room amongst everybody. Thank you.
Thanks. Lavina, can you come to Georgia February 11th and help them with it? Do something? Okay. Talk to Lavina right here and we'll. Okay, all right, okay, perfect. Did somebody else, yes, ma'am?
Yeah, I'm Dr. Lulu Bridges.
Okay.
Yeah,
Sorry.
I am from Montgomery, Alabama. I serve a lot of the Black Belt counties within Alabama. At least we used to. We had a lot of funding, but I was standing for one reason in particular. When you were talking about the list that you wanted to add, have you done this? Have you done that? Would you like? I was hoping that you would also put on that list, would you like help with substance abuse disorder? Mm-hmm. Or would you like help with information about substance abuse? Because when you look at the whole picture, a lot of times substance abuse is at the core of it. So if you don't put that question on there, then they miss an opportunity to even do a telehealth with a counselor. So I'm just saying that would be a really nice thing to put on that list.
Yes, ma'am, we will add that. Do we have any other audience questions? Right? What I would like for y'all to do is get me out of here with what you want them to know before we go, what you think they need to know before we go. Other than that, I'm great. Don't use that one.
Hi, sorry, I don't know.
Oh, go ahead. Oh, go, sorry.
Like last question. So I run a syringe exchange for Fulton County Work Hub, and we work in close conjunction with Georgia Harm Reduction Coalition, and also Access Point. A huge barrier for us is funding, and like the entire process for opioid abatement funds for the state is completely nebulous. Everything's behind closed doors. I was just wondering if there's any resources or advice on how to kind of like make this a little bit more transparent. Also, to Dr. Sullivan's point, like we have no idea or say so in how these funds are going to be spent when they should be given to organizations like GHART and also Access Point, us to really mitigate this issue.
Do you get our opioid abatement newsletter, our opioid settlement newsletter, which tells you where every dollar is going sign up for that thing right there. Every 2 weeks, we put out a newsletter for all of the Appalachian states. It gives an update of what's happening. If you send us a note or a request about your specific county, we'll do the deep dive into your specific county for you. All you have to do is sign up for that newsletter and either reach out to, what's Raleigh's last name, Martinson. Raleigh Martinson at Community Education Group, or Dr. KBV at also a Community Education Group. But if you get that newsletter and it doesn't cover your county, call me and heads will roll.
I'm Holly Lindy. I'm the Executive Director of the Georgia Opioid Crisis Abatement Trust. So I would love to chat with you afterwards about how we are handing out the funding. So I got all the information. It's also Ms. Taylor Dayton. She's my team member. But actually, one of the things I did want to address was 2 things that you all said that makes me actually feel very good. So we actually, in our statewide and regional advisory councils, sorry, we have a lot of advisory councils. We actually have on each of the 6 of them, we do have, and it actually is in the settlement MOU that we have to have somebody from the Department of Public Health. So we do have that, and then also most of our funding, our funding actually is divided regionally, and it has to go, some of it, the regions that have the highest number of opioid overdose deaths, plus the number of pills shipped to them, actually get the most regional funding. That is Region 1, which is at the top. So it's good to know that that your recommendations are something we're already implementing. So please, if anybody has any questions about the opioid abatement, please come see me after this. I'm here.
Yes, ma'am.
I'd like to know, you were speaking about going to West Virginia, do y'all have scholarship?
If she raises all of the money that she's supposed to raise, ma'am, all I do is look pretty, ma'am. I turn certain things over to certain, so did you hear the question? Gloria, the question was, will there be scholarships available?
We've had to get everyone in this room to donate to it.
We hope so. We did last year. We hope to do it again. We are literally in the beginning stages of our hard fundraising push for, I'm teasing her, but me, Lee, Lavina, Brandon, everyone on our team is committed to raising the resources that we need to bring. I think last year we bought 2 people from each state. Is that right? We gave scholarships away for at least 2 people in each state. We hope to be able to do more this year, but right now we're just trying to make it work. You know what it is. We're trying to make it do what it do. Got you. I'm trying to make you do it. All right. Let's go down the line real quick. Speed answers.
Okay, really quick. Syndemics. This means nothing is in a silo. That's not how the world works. It's not how that we should be approaching problems. That means that there's everything from grading funding to community building to mutual aid. thinking about, what are the root causes of issues. And working together, I think gatherings like this are really important where you're bringing in folks from multiple sectors and multiple places to talk about multiple issues that affect lots of people. It's hard work and it's just, we need to keep doing this together.
It's good seeing you.
My work was also syndemics. And just to re-emphasize that, like when these health conditions co-occur, they are completely because of the way that we've built society, resources, and I think this has a lot to do with structural and social determinants of health. And so I think we need to be intervening around the infections. That's important. But I think we need to keep this discussion about the social drivers and the common social drivers just at the front of the table. And my other word is maps, that we deal with people who ingest information in a lot of ways. And for a lot of people looking at a table with statistics in it, makes their eyes roll back. I have one child who cannot look at numbers and another who loves them. We're all built differently. So I encourage you, if you look at HepView and AIDSview, if you need maps that illustrate your jurisdiction, your cluster of 3 counties, email me or email helpme@aidsview.org, and we can make custom kinds of maps to help you make the point. But people take information in different ways, and maps are a great way to tell that story.
I was running the microphone around. Can you repeat the question?
What do you want the people to know before they go?
Oh, you have the answers. You literally have the answers. Your question literally is a rock throw away. So I think we just have to continue to lift up our voices when we get into spaces like this. I would say spaces like this also are your social media platforms. So speak, really go through the comments, even if you like just one comment. Like, these girls like to talk, so just like it, see what you find out, but we have the answers inside of our rooms. Yeah.
I think for me is that there's a lot of change, as I mentioned earlier, we're on the eve of a lot of change. And I think that can be very scary, right? That makes us can make us unease. And I think a lot of us live in intersections of vulnerability. And so I think making sure that we take time for ourselves, that we pause, and find joy that the sun is out, right? And then do the work. Find joy that you're having dinner with your partner, with your parents, and then go do the work the next day. Put down the phone, put down the laptop. As hard as it is for me to do that sometimes, I think we need to make sure we take care of ourselves in these times. Because change is coming, and I think we're starting to feel that already, right? I felt this certainly January 2nd when I left my office and packed the box. But I think this work is going to change as well. And I think the way we talk about things might have to change. It doesn't mean that we need to stop doing what we're doing. It means we need to talk about it differently, maybe, right, to certain people. And so I think just thinking about what that means for our work, at the end of the day, we need to stay focused. We've had progress, but we also know progress is vulnerable, right? So how do we continue and maintain that momentum? And it may just mean changing the way we sort of frame it, the way we do the work. But at the end of the day, the work still continues.
Thanks, and I'm gonna say that I believe that we can do it. I believe we can end it. There's a line in the original version of the National AIDS Strategy, which is, I'm gonna paraphrase it, but it's probably the thing that I live by, and that is that we can't do it alone. Not if you're people living with HIV, not academics, not faith-based people, not policymakers, not whatever. It's not, it's an us solution. And I think that we've got to keep expanding who the us is that we bring into this to devise that solution. And when I look across rural America, I think that often we don't pull them in enough, and I want to do more of that. I think when we look at people with lived substance use disorder experience, we think we know who they are, and we say that they have these iterative lives, and therefore we can't. And I think sometimes we forget that there are people that use drugs and go to work every single day. Every single day. And so I think that we've got to figure out who the we are that we're talking about, and I think we can do it. And I think, and I go back to the we, that we can do it. I want to thank each and every one of you taking time out of your day to spend a little bit of time with us. Please follow us on all our social media platforms. And if we can ever do anything to work with you, partner with you, we will. There's information out on the table. I hope you had some good lunch. If not, what are you gonna do? Have a great day.